So good morning, people. We are really excited today to learn a little bit more about AI from one of the experts in this field, who's also a nephrologist, a critical care nephrologist, Dr. Sakhuja. He's a dual trained critical care and nephrology board certified, I think, who works mostly in critical care now at Mount Sinai. He's a physician scientist and he's an executive now with expertise in reinforcement learning, AI, clinical informatics. Apart from the clinical critical care medicine and nephrology, he serves as the associate CMIO for AI and critical care at Mount Sinai in New York. He's the director of their AI and informatics at the Institute for Critical Care Medicine, and also the director of the clinical informatics research in the division of data-driven and digital medicine at the Icahn School of Medicine. They have been doing a bunch of stuff with AI in research as well as in clinical informatics. So we are really excited to have Ankit here. Welcome.
Thank you, Swapnil. Thank you for that kind introduction. And again, thank you for inviting me. Um, these are my disclosures. Now, over the next 45, 50 minutes, what I want to really talk about is that why in healthcare, especially, we think that artificial intelligence is going to be helpful for us, right? And then we'll talk a little bit in depth about some of the common artificial intelligence methods that are out there, because I think it's important to understand what those methods can do to be able to apply them effectively in our research and our clinical practice and QIs and whatnot. And then we'll also simultaneously talk about some of the limitations that these methods have, because I think that knowing the limitations of these things is even more important than knowing what they can do, right? So let's start with, why do we care about artificial intelligence? And the big reason is that artificial intelligence is everywhere these days, right? From the thermostat in our houses to our cell phones that have these facial recognition softwares and navigation apps, text editors, virtual assistants, chatbots, and up till these self-driving cars. There are so many things these days that are powered with artificial intelligence. And that is why we are interested in it, right? But what about in healthcare? So we looked at the utilization and publications of various artificial intelligence techniques. And this is an excerpt from that study, which very clearly shows you the uptick and an exponential uptick in various artificial intelligence related publications in the last 10 years or so, right? There was a lull moment and then it just took off, and it's still taking off more and more. And this is why it's important, right, for us to know about it, because this is directly affecting both our personal and professional lives at this point. But then the question is, why do we think in healthcare it's going to be really helpful? What can it really do, what we can't do without artificial intelligence, right? And one of the reasons I think why we think that AI can be helpful in healthcare is because we have so much data, right? When you write a note, you generate data. When you review labs, you generate data. When you review ultrasounds, you generate data. You review ECGs, you review, patients have these waveforms on the bedside. That all is generating tons and tons of data, right? But then the question is, can't we just utilize this data ourselves? Do we really need a machine to tell us how to utilize this data? We have been doing this for eons, right? So this was the exact this is the exact thing that we need to hone down on, right? That can we utilize this data effectively? So it really comes down to how much data is there. So this is a study, a little old study from Canada, looking at ICU patients. And in that time, they predominantly just looked at structured data points that a patient in the ICU generates. And as you can see over here, a patient in an ICU generates ballpark 1,400 data points in a 24-hour period. An intensivist in the US sees, I would say, at least 14 patients a day. That's almost 20,000 data points per intensivist per day. How can anyone humanly process that amount of information, right? And this is why maybe we do need some help with technology. But then again, we've been doing this for eons, like we were talking. Why aren't we just good enough in doing that? So what's the data on that? And this is a study that looked at that exact same question. This study was done by Icahn and Vitali at Mayo. And they asked their clinicians that when you're making a very simple decision about admitting a patient to the ICU, what are the data points you look at? And uh, they came up with this laundry list of data points that they evaluate, right? And some of them very valuable, I think, ahead of times, right? Then Vitali and Augie went one step ahead and mapped these data points into medical concepts available in their EHR at that point, and they found that it got mapped to about 3/4 of the EHR, which is mind-boggling that we think that we need 3/4 of the information available in EHR to make a simple decision about admitting patient to the ICU. But the flip side is it shows you how complex some of these decisions are, right? Then they went one step ahead and they were like, let's see what happens when rubber meets the road. And then they found that when clinicians are actually making these decisions, at a median, they use about 11 of these, 50 some concepts. But in most of the cases, it just comes down to four things: heart rate, respiratory rate, blood pressure, oxygen saturation. Majority of people just look at that and they're happy, right? Out of those 50 some concepts that we think are important. So this kind of, shows that, we may not be as good at utilizing all the data that is there as much we would want, right? So it kind of lends to that maybe, if technology can help us with this, it may not be a bad thing, right? Now that gets us to that if we want to use artificial intelligence, we need to understand what artificial intelligence is, right? Now, if I ask my kids who are 7 and 9, they'll be like, well, duh, dad. I mean, artificial intelligence is science of making intelligent machines, right? Then the question becomes more complex. What is intelligence? And intelligence is all of these things. But if you think about it at a very, very elemental level, intelligence is the ability to learn from past experience and then be able to use that experience in new situations, right? If you can do that, you have intelligence, right? So with artificial intelligence, all we are trying to do is give computers and computer programs the ability to learn from their own experience and then apply that learned behavior in new settings, in new data sets, right? In new situations, to be able to do those things somewhat autonomously, right? So we don't have to keep going back and code again and again the same thing and tell them again the same thing. Now, with that, let's talk, about various types of artificial intelligences that are out there. I mean, these days it seems like there is a new algorithm comes out every day, if not every few hours, right? But again, if you really think about it, you can put all artificial intelligence models in these three buckets: machine learning, deep learning, and natural language processing. And let's delve a little bit into what each of these things is. Machine learning, it's just very simply, we are writing codes so that such that the computers get the ability to learn from themselves. But again, the key point here is we are not doing any explicit programming. For example, in the conference room, you guys are sitting over there. if I want to write a program to have a robot walk from one end to the door of the conference room, a way to do that is I will write in explicit instructions: 2 steps left, 1 step straight, 2 steps right, 3 steps straight, 2 steps left, and you're at the door, right? Something like that. The other way is I'll program in the robot that, if you hit the table, if you hit the chair, if you hit the walls, if you fall, that's a no-go. You have to find the shortest path and get over there. It's going to be a little more complex programming than that, but once the robot runs and learns that, that's magic, right? And that is what machine learning is all about. Now, in machine learning, there are 3 broad categories of algorithms that are there. Something called as supervised, unsupervised, and reinforcement learning. So let's see what supervised learning is. Let's say we have this basket of fruits, right? We have some apples, some oranges, some bananas. And we want to write a program that can segregate these fruits based on the type of fruit, right? So a way to do this is that I tell the computer that, this is what an apple looks like, this is what an orange looks like, and this is what a banana looks like, right? Now, again, the key thing here is I'm not telling the computer that these are the dimensions of apple. This is the color of apple, right? I'm just giving it ballpark, the end result, this is what it looks like. So it's going to make an effort to do that and might come up with, something like this, which may be fine, which may not be fine, right? So we'll ask it to rethink its strategy, train again, and after, few means few hundred and few thousand training sessions, it may come up with a better scheme. Now, it never is 100% accurate. 100% accuracy is just a myth, right? If it's too good to be true, it is too good to be true. But still, it can get pretty good. Now, the magic really happens when we give it a new data, a new situation, and it can use that training to be able to come up with a similar strategy to segregate fruits, right? This is the power of machine learning, that I did not have to code those things again to do it in a new set of data, which in case of statistical programs, I would have had to, right? Now, very, very simple example of a supervised machine learning program is the regression models that we have learned, forever, right? They are a machine learning model. A little more complex is something called as a decision tree. So, like, I like to play golf. And when I go out to golf, besides making sure my wife's happy or not angry with that decision, I have to still look at the weather, right? And as it turns out in New York, if it's cloudy, it's a good day to play. But if it's sunny, I need to watch out humidity. We are close to the sea. And if it's too humid, I may not be able to play, right? And if it's rainy, I need to also look at how windy it is. And if it gets too windy, I may not be able to play, right? So this almost creates this flow chart or this decision tree I can follow to play golf. But now let's say I want to play golf in LA. I want to play golf in Toronto. I want to play golf in Paris. I want to play golf in Mumbai, right? I will need to create a separate decision tree every time and keep tabs on, which decision tree to look at. That gets very challenging, right? As you grow more and more of these trees. So what can we do? So one thing we can do is exactly that thing that we grow these trees, we create these trees, these decision trees for each separate city where I want to play golf. But then to simplify my life, we aggregate the results of all these trees, right? So that now we have one decision tree that I can always look at when I want to go and play golf. It won't be 100% accurate for each city, but it will be broadly applicable to every city, right? The other way is that I create a decision tree for New York, and then every next city I go, I incorporate the findings of the golf courses, of the weather of that city into this, and keep iteratively improving this tree, right? Now, these are very, very powerful machine learning techniques. The one on the left side of the screen, what you see is something called as a random forest, because these are trees, and this is a randomly taken group of trees, so a random forest, right? On the right side of the screen, what you see is another very, very powerful machine learning technique, something called as gradient boosting, because we are boosting the performance of these decision trees with every iteration. Even this in this day and age, if you pick up machine learning papers, you are bound to see many papers that are using one or the other technique or some variation of that. Now, at Sinai, we have a model that is built on these decision trees, something called as a must plus classifier, to identify malnourished patients in the hospital. And this model performs better than a non-artificial intelligence classifier must to identify these patients. And at Sinai, the nutritionists get an alert when this model identifies a patient who may be malnourished, so that they can do their evaluation and provide care to that patient, right? So you can see these can be very, very powerful models. Now, another type of machine learning technique is called as unsupervised learning. So let's say, we have the same basket of fruits, but now I'm like, I'm not feeling it. I don't want to tell the computer what's what. Let's let the computer figure it out. And as it turns out, using unsupervised learning, the computer can still figure it out, right? Now, it will not know what's an apple, what's an orange, what's a banana, because they are just made up names and we haven't told the computer, right? It might say that these are different subphenotypes of fruits or different clusters of fruits, right? And this is a technique that has been used ad nauseum to identify these various subphenotypes of patients in what were presumed to be, homogeneous populations till not long back ago, right? Be it sepsis, be it ARDS, be it AKI. But this again shows you how powerful this technique is, right? Where it can find patterns where we don't see patterns. But my most favorite one is reinforcement learning. Uh, Anybody here has sat in driverless cars so far? You guys have. How's the experience?
It's initially very scary, but after a couple of minutes, you forget that there is no one in there. This is the Google Waymo. It's a bit
Okay.
scary. Yeah.
So, those cars are trained on reinforcement learning, right? So very simply, let's say, there is this kid and her parents want her to get from this table to this chair, walking, not crawling. So what will they do? They'll ask the kid to get up and take steps, right? And if the kid takes the steps the right way, doesn't fall, they'll give her accolades. If she takes a wrong step, falls, she gets a boo-boo, right? So when she's getting accolades, that's a positive reinforcement. When she's falling down and getting boo-boos, that's negative reinforcement. So the kid can learn by herself how to take steps that, if my left foot is in the front, the next time I need to put in the right foot, and then, the left foot. If I stretch my foot out too much, I might fall, right? So even without explicitly telling every time that you need to get your foot 5 centimeters in front of the next foot, the kid still learns to walk using reinforcement learning, right? Now, in this very simple example, if you put it in reinforcement learning terms, right? This kid is what we would call as a computer program or the agent who's taking actions. The environment in this case is the floor, the table, the chair, right? If this was a patient scenario, the environment is going to be the hospital, the unit, the patient's room, or the data set, right? Now, for this kid, whether the kid is fell flat on the ground or the kid is standing, left foot is in the front or right foot is in the front, that all is the state of the kid, right? Or the clinical characteristics of patients. Actions for the kid are, left foot front, right foot front, right? Those are the actions. There can be numerous actions in case of patient care. The rewards that the kid is getting are positive and negative reinforcements, right? And as it turns out, computers are as greedy as humans. So we can program them to get the maximum reward. And they do pretty good with that. And based on this kid is learning this policy as to how much of which foot she needs to put in the front so as to be able to walk and get positive reinforcement and not fall and get negative reinforcements, right? And if you think about it, this is how we learn everything in life, right? Now, at Sinai, in our lab, we use this very powerful technique to develop a model to personalize glucose control in ICU. On the left side of the screen, what you see is the rewards that the model gets are much higher than the rewards that clinicians get. And these are rewards based on, appropriate glucose control for patients. On the right side of the screen at the top, what you see over here is that vertical dotted line. That vertical dotted line signifies that the doses recommended by the model were the exact doses that clinicians gave to the patients. And when that happens, that blue line shows that the average time in range for an appropriate glucose control, which is glucose control less than 180 in an ICU setting without going into hypoglycemia, was the longest. And the average glucose level in orange is pretty good. But as you go to the right side of those graphs, that is when the model is saying give more insulin, but the clinicians have given less insulin. And you can see the time in range acutely drops and the glucose level starts to get higher and higher. And you see the similar thing in the graphs at the bottom of the screen, where you see that when the glucose level was lower, the model recommended much lower insulin dosing than what the clinicians gave. And when the glucose level was higher, the model recommended much higher insulin dosing than what the clinicians gave. But then again, the question is that, yes, I mean, yeah, this is a computer program. It's going to tell me, how to dose insulin. I've been doing it for the last 20 years, right? How many times do you hear that? So we took one step further. We got a group together that included endocrinologists, included advanced practice providers who round in the cardiac surgery ICUs. We got junior cardiac surgery intensivists, which we defined as less than 5 years of attendingship under their belt, and senior cardiac surgery intensivists. And we gave them a 24-hour time frame of the patient's history, right, with all relevant history. And we said that you have full autonomy. You can even see what happened with the patient in the next 24 hours. Now you generate your best case insulin dosing for this patient, looking at all that, right? Then after we got all those dosings, we blinded those dosings. And then we got a group of senior cardiac intensivists. And we said that, now you evaluate each dosing scheme for safety, efficacy, and applicability in a cardiac surgery ICU. And what we see over here is that in this blinded evaluation, the performance of glucose was pretty remarkable. It was considered as safe as clinicians, but it was considered more effective and more acceptable than the combined clinician policies, right? In no way it was inferior to any of the clinician policies at all, which is pretty remarkable for an artificial intelligence model, which is giving prescriptive guidance, right? All right. So let's move on to deep learning. Now, I'm sure you all have by now heard this term deep learning. So what is really that all about? Deep learning is built on the concept of biological neuron. So like the neuron gets inputs, processes, gets outputs. An artificial neuron gets inputs, processes them, and gets an output. It's exactly the same thing. But if you look under the hood, this is just a mathematical function, right? Now, let's say this neuron is getting 3 inputs, and let's call them W1, W2, W3. And it has to process those inputs to make a prediction, just like, the simple machine learning one, right? So what it is going to do is it is going to give different prioritizations to each of these inputs. And it's just going to do it randomly. It'll just pull it out of the hat because it has no starting point. It does that. And in this iteration, in this first iteration, it's giving the highest importance to W2 and the least importance to W3. Then it comes up with a weighted sum of this, and it compares that weighted sum with this function f of x, which is called as something as an activation function, right? What this function has stored in it is a threshold which decides whether this model should fire. Just like in biological neurons, right? Our neurons have some pre-programmed information in there to know whether they should fire or not. And that's exactly what it is doing. It also has information that we can pre-program in there to know if it fires, what should the result be. If the result is not closer to the ground truth, the whole iteration repeats, where it plays with how much importance it is giving to each input. And again, depending on the complexity of the case, there could be hundreds to thousands of these iterations before it comes up with these importance levels or weights, as they are called as, for the model, which will give a good prediction. And then that is the model that is frozen and validated and whatnot. But just like in real life, one neuron is seldom enough, right? We need multiple neurons. And when we have multiple neurons, we put them in different layers, where the first layer, all it does is it sends out the input. The last layer just catches all the output and shows it. And it's the middle layer where all the processing happens. That's called as the hidden layer. Now, when you have two or more of these hidden layers, it's called as a deep neural network. And that's where this, depth is. And that's all the depth is in the hidden layers where all the processing is happening. But in healthcare, things are still not that simple. And I'm giving ICU examples because that's where, I spend most of my clinical time. So I'll give you another ICU example. Let's say, there is a patient who is in front of me with a map of 50. We all know that's not a good thing, right? So I have to do something. I have to get that map up. Just knowing somebody's map is 50 is probably good enough a start, and I can do some things to get that map up. But even better would be if I can know that before I got here, what was done to this patient and what happened to that map because of what was done, so that I can make a more effective decision, right? So in a way, what I need to know, or if I was this hidden layer where I'm making these calculations in my head, what I need to know is not just what the map is, the coming from the input layer that I'm getting, but in the previous time step, when somebody did some calculations in this hidden layer, what was the output of that, right? So each hidden layer is getting a input, not just from the input layer, but from a time step before from itself, right? So you're building time series into it now. And these are very powerful models called as recurrent neural networks. But the limitation of this is they can only peer like a step or two back into past. That's a good start, but that's rarely sufficient, right? So then we have these models called as long short-term memory networks, or LSTM models, which can peer far back into the past. And not only can they do that, they can prioritize. They can prioritize which information they should remember in the long run to continue to incorporate in the predictions, and which information they need to incorporate only for few short runs and then they can forget, and they can do it by themselves. We don't have to program that in there, right? We used this very, very powerful architecture to identify patients at risk for MAKE 30. Now, you guys all know MAKE 30 is this composite outcome with death, dialysis, and persistent kidney dysfunction, right? We created an LSTM-based model, and we compared its performance against a standard Cox proportional hazards model. And you can see over here that the LSTM model has much superior performance in comparison to a Cox proportional hazards model in identifying these patients, right? So it shows you that these powerful techniques can be used to further enhance what we have so far been doing, right? So it's not something totally different than what we were doing. It's just an extension of a better way of doing things, right? Because again, going back, regression is just machine learning done in a little bit of a different way, right? Now, this all was very cutting edge till 2017 when Google's DeepMind came out with this architecture called as a transformer model. And this turned the whole world upside down. This is still in 2025 a state-of-the-art model. All the large language models, ChatGPT, Gemini, Claude, Grok, whatever you use, they're built on these transformer architectures. In our lab, we use this transformer architecture to identify patients in the ICU who are at risk for underfeeding. In an ICU, patients have, 10, 20 different things going on with them. And feeding them, unfortunately, doesn't every time rise to the same priority as keeping them alive for the next hour, right? So underfeeding in ICUs and is unfortunately more common than what we would want. And until now, there was no good way to identify patients who are going to be underfed. But using this transformer architecture, which can account not just for time series, but it can account for time varying covariates in a very, very powerful model. We can now identify these models. And here is the performance comparison with XGBoost, a gradient boosting model, another very powerful machine learning model. And you can see that's no match for a transformer model. Now, the beauty of these transformer models is that they can go way back into the past. So they have a lot more temporality built in. But not only that, they can understand by themselves that in that whole past, what is relevant for this time step. And that is what makes them so powerful. Now, another type of data that we frequently use in healthcare is imaging data. The question is, how can artificial intelligence help with images, right? Now, you think about it, this image is really, just a group of pixels, right? Now, if we can just convert it into a group of pixels, what this becomes is just a matrix. It's a matrix of numbers at this point. So the way an artificial intelligence model looks at it is just a matrix. And then it takes a magnifying glass and um, we can program in how big a magnifying glass we want, but it takes a magnifying glass and starts looking at different segments of this matrix, right? To try to identify what's important in that entire segment that it's looking at. And it does that for each segment and creates a smaller matrix that is a little more workable, but with more high yield information, if you will, right? Then it takes another magnifying glass and gets what's most important of these things into a much, much smaller matrix. Now we do this for various features. For example, in that chest X-ray, there could be a layer of this model which is looking at the color. There could be another one which is looking at edges. There could be a third one which is looking at contrast of the image, and yada yada yada. So in reality, there are multiple of these layers running in parallel doing these things. And then ultimately it comes up with an output which tells you whether this chest X-ray was normal or there was some abnormality in there, right? But this is essentially what happens behind the scenes. Now, this is again a very powerful technique. In our lab, we have used this technique to read ECG because ECG at the end of the day is just an image. And we used it to read ECG and identify right ventricular ejection fraction from ECG using this very powerful technique called as convolutional neural network, or CNN. So again, very, very powerful techniques, as you can see. All right, let's talk briefly about what natural language processing is. This is the third bucket of AI models. And put simply, it is training the computers to communicate in our language and understand our language, right? At the end of the day. This is one of those fields which has seen an exponential growth in last few years. Not until not long ago, if you gave the computer these three sentences, all it could do was count the number of each words. That was the best it could do. Then maybe about 8, 10 years back, it could capture these semantic relationships. And then very rapidly, it can understand context. So the number of applications have grown, as you can see, using these natural language processing programs, which can now read these languages. So at Sinai, we routinely now extract information which is unstructured in patients' notes, et cetera, for both R&D and many operational purposes. So that, if you think about it, more than half of the information, up to 2/3 of the information by some measures, is available in unstructured form. Until now, all the research work, all the operational work, all the quality metrics, etc., we would all just base it on structured information because it was just painful to get information which was unstructured out. That's not a limitation anymore because of natural language processing. Now, a hybrid of natural language processing and deep learning is something called as large language models, right? Which is, I would say, the most democratized AI models out there, most public-facing models that are out there that almost everybody has used at this point, right? Now, when I was in med school and I was being taught statistics, I was told that you have to be very, very meticulous in when you create a statistical model. You have to make sure every variable that you put in there has biological plausibility. It has to be statistically tight. It's not that you put whatever you think is right in there, right? And then you meet large language models. The way you train them is you take the whole internet and then some more, and then you train a large language model, right? This has been possible, again, because of these very powerful transformer architectures. Before that, there was nothing out there that could handle this much data, this much complexity, this much context. But transformer models are the ones that have made that possible. But what do these large language models get trained for? What are they doing? In the end, they are just predicting, right? What are they predicting? They are predicting what we call as the next token. Token is just a group of characters. It could be a full word, it could be a partial word, it could be a combination of words. That's all they're predicting. These large language models are not trained to write an essay, to review a paper for you, to solve a mathematical equation. They are just predicting, in a very simple sense, the next word. And you can see that because of this transformer architecture, what all they can do just by predicting the next word. Now, to give you an idea of how tokens work, let's say we take this sentence, and you can go on Google and search tokenizers. So OpenAI has its own tokenizer. Many other large language models have their own tokenizers. But the way it works is when you type this sentence in any large language model, it tokenizes it. So, for example, in this large language model over here, you can see how it tokenized. But the key thing to look at here is that every word after the first "the" includes the space as the whole token. If you take that space out, it becomes an entirely different token that the model is looking at, right? Then it looks at these tokens and then runs the algorithm and sees what should the next token be. And then whatever comes up at the highest level ends up being the next token that it spits out. This at the very, very simple level is what the large language models are doing. Now, if we had a different sentence, you can see how the tokens split, because in the last sentence, the tokens were pretty much like the word plus minus, the space. But here, the tokens are very different. than than a full word, right? Some of them don't make sense. But then the beauty of these large language models is that with this training, with the transformer model, they can be adapted to these wide variety of tasks, right? And again, having lots of data is good, but being able to process that data to understand the structure of the data is what makes these large language models so powerful and so uniquely useful. All right. So in the last few minutes, I want to talk about some high yield take home points. The first thing I want to impress upon is that AI is not going to be our future. That's just not going to happen. AI is the present. It is already here. The question is whether we are the part of the change or we get changed, right? We are at that golden moment right now, I think, where we have the luxury of using AI and evolving AI so that it can help our workflows, right? Be it in personal lives, be it in professional lives. But if we don't capture that, AI is already here. It is going to get incorporated into things. It may just not get incorporated in a way that will be helpful to us, right? A perfect example is electronic health records. When they were built initially, they were not built in a way that would have improved clinicians' workflows, right? So until this day, we keep putting bandages on that, right? And if we are not ahead of the curve uh, in defining the adoption of AI, we'll be playing that catch up for the next decade with artificial intelligence also. Another thing I want you to take from this is that AI is not going to be a cure-all. What electronic health record do you guys use there?
We are Epic.
You are Epic. Okay.
So
So this is perfect. So Epic, few years back, came out with their version 1 of sepsis model, and now they have recently come out with their version 2 of sepsis model. Now, this model, right off the bat, had not that great performance, right? But what was very, very interesting was that the input features it was using to predict sepsis included orders for blood cultures and orders for antibiotics. As a clinician taking care of sepsis patients every day, I'm thinking, if I have already made the decision to order cultures and antibiotics, I already know this person has sepsis. What is this model's prediction going to add to that except clutter, right? And this was looked, and when people took these input features out of the model, I mean, my kids can probably predict sepsis better, right? So this shows you that you can't just put AI in front of a problem and the problem will get solved. Still a lot of the thought process, the same rigorous methods that we use for any research, any operational task, any QI task have to be there. AI can help augment what we are doing, but it's not going to miraculously solve problems. Now, another very real concern as AI is getting very deeply integrated into our workflows is bias. So this is a study for AI used for skin cancers. And as you can see over here, the Fitzpatrick skin type in blue, 1 and 2, that's lighter skinned, orange one is darker skinned. And all these different AI models performed better in lighter skinned individuals because a lot of these models were trained in data sets which had a higher preponderance of patients with lighter skin, right? So it becomes very important now as these are getting integrated to know what was the training sample for these models. is this going to be applicable in my setting? Because if my situation where we want to deploy this model is very different than where it was trained, it may not perform that well, right? And it's not model's fault. It's just how the model was trained. But all this model does is identify patterns. And sometimes it's too good in doing that, right? And that's why it latches on to these biases. This becomes even a bigger concern looking at this example. So this is a study by Judy Gichoya, who's an interventional radiologist at Emory. And what they found was very mind-boggling, that if you give these AI, the vision AI models, an image of a chest X-ray, and you can blur the image, you can hide, parts of it, most of it, whatever, it can identify demographic information about the patient from these images, which even experienced radiologists can't. So it tells you that there could still be the model could still be biased, even though we think that we haven't given it any information which should bias the model. And if we don't know that the model is biased, the model may be making recommendations latched onto that bias, which may get implemented at some point without us even knowing, right? So this is a real problem. Now, another, I think, big thing I want you to take home is algorithm metrics. And we are, at a time now where AI models are coming from left, right, front, and center every day, right? And just like, when you're writing a grant, you try to show the side of the side of the car, which is, well polished, not like ridden with bullet holes, right? Same thing goes with when you're trying to pitch an AI model. You show the best metrics, not necessarily the whole story. For example, a very common metric for AI models is accuracy, right? And accuracy, the best accuracy is 100%. But let's say that you ask me to make a prediction for mortality in a group of your patients, right? And the mortality is 5% in your patient group. That's it. And I'm just not feeling it. And like, I can I can I can game the system. And what I can do is I can create a model that's never going to make any prediction for mortality. It's going to be the most optimistic model, right? The patient could be near death. The model will say, oh, the patient will live, right? What's the accuracy of this model? 95%, right? It's an absolute garbage model. The accuracy is 95%. So, and I think this is a whole discussion in itself and how to evaluate models. But just looking at some, spot metrics for AI models, just like, for statistical models, is just not sufficient. You have to look at the whole picture and you have to look at metrics, which in your case makes sense. And then finally, AI is just a tool. And as the saying goes, a fool with a tool is still a fool, right? So it comes down to finding the right question and then finding the right algorithm. Maybe AI is just not the right thing to solve a problem, right? Just because we are living in the world of AI doesn't mean we have to incorporate AI in everything. Some things are better done without AI. But if we are using AI, knowing what an algorithm can do is very helpful. But knowing what an algorithm cannot do is even more helpful so that we don't end up in this situation that's shown in this cartoon. So to summarize, AI is a very, very broad area, very rapidly evolving field. I think it is extremely important for all of us to be involved in this. And it could be, it doesn't have to be that you are the one who's coding or you are the one who's doing research, right? Or you are the one who's doing operational work. Even as an end user, it's very important for us to be involved in usability testing of these models, and providing our feedback to make sure that as these models come, they at least don't deteriorate our workflow, right? Because then that beats the purpose. And it is critically important, I think, to be aware of some of these various limitations of artificial intelligence that we talked about. I'm happy to take any questions.
Thanks, Ankit. That was a really nice overview, especially, going through, people use AI when they mean, deep learning or sometimes regression, right? So it's really useful that you walked us through all the terms that are there. If there are questions from the audience, yeah, Dr. Noel.
Thanks. Sorry if you touched on this. I missed the start of your talk, but how do you see this? The one thing I keep thinking about is in medical education. So we spend so much time teaching students, signs and symptoms and what diseases link to that. We often teach them lists of things, causes of AKI, how do you treat pneumonia? It's all this sort of stuff now that if you're up on the ward, you can get it in 5 seconds from a model. So, like, what do you think is going to happen in, I don't know, 3, 4, 5 years with medical education? Because I find sometimes now, if you have a little talk on the ward about something, it's almost irrelevant in the way, if you think about it, you're going through some, I don't know, some breakdown of acute kidney injury, when in reality they could, quickly figure this all out, and they, so I find sometimes that the students that are really using it are kind of disengaged with what you're saying or find it not as relevant. So I think we're teaching a very old way of teaching. And I'm curious what people in the medical education field think, and really maybe all of education in areas that are really cognitive and non-technical, and a lot of medicine specialties are, where this might be headed.
That's a very, very good question, Dr. Noel. And I will preface it by saying that if I was really good at making predictions, my office would be 60 blocks down at the Wall Street. But having said that, I think, if I have to give an analogy to what might happen, when, a few hundred years back, when stethoscope was invented, before that, physicians, as I understand, used to have to put their ear to patient's chest to really figure out what was going on. When stethoscopes came around, that skill got lost, right? Now, few years back, with point of care ultrasounds, not many people know how to use stethoscopes now, right? But they can find the information, I would say sometimes even better with point of care ultrasounds than with stethoscopes. But the flip side of that is that the skill of using stethoscope is getting lost. So if I think about it, we are replacing our skills of physical exam based on what is technologically superior in helping us find the answers that we seek. And I feel the same story might unfold with artificial intelligence. For example, the way we were trained is to take a good history, do a good exam, put everything in perspective, think about things, come up with a list of differentials and a plan that addresses those things. Now with AI, and AI, I won't say AI is there yet in doing that, but it's getting to be good, where soon enough an AI model may be able to do that, in a broad sense, right? And then maybe there won't be need to have that skill that we inculcated so patiently over our training years. But the skill at that time might be how to make sense of what the AI model is saying. how to spot when an AI model is hallucinating, how to spot when an AI model may be missing things, how to spot when an AI model may be wrong, how to get the AI model to do better than what it is doing while achieving the same goal of improving the care of the patients, right? So I think the whole approach uh, to our professional lives might evolve along those lines.
Yeah, that again, if I could ask a sort of related question, I think you're absolutely right. Is rather than close our eyes and pretend it doesn't exist, the kids are using LLM models, and we have to learn about their limitations, weaknesses, and strengths. But is there something we could learn from the model output itself? Like taking your example of that glucose to me was like mind blowing. I think we are sort of anchored to not make big changes, like especially at the low end when things we should be really de-escalating the insulin dose or going really high. We are very conservative in making changes. Is it possible that it's not just reinforcing the machine learning but reinforcing human learning to say, hey, uh, look at what the machine output is, and maybe we could do things better, or by looking at the machine output, and maybe we don't need to if we have got a machine telling us what's the right thing to do. Is there anyone looking at these kind of things? Is can we become better clinicians by using that to improve our thinking and our cognitive biases?
That's a very, very good question, Swapnil. So there has been some work done in radiology where, very interestingly, what they found is that when you incorporate artificial intelligence, the performance actually declines. Now, could that be because clinicians say that, oh, if AI is saying that, that must not be true, right? There's probably an element of that there, but that is where I think the human-centered design, when we are developing these models, and usability testing while we are developing these models and deploying these, becomes very critical, because a big part of these AI models is that they need to integrate with our workflow, right? And they need to make our lives easier. If they don't make our lives easier, it's just not helpful. Nobody is going to use them, right? We don't want to create new workflows to incorporate these models. And this is where I think, that we all can probably help a great deal. All of us who were trained in eras before artificial intelligence, because we have that insight as to how we as humans think, right? People that are training in the AI era, their thinking is probably somewhat, a mixture of how AI thinks and how they think, right? But we have, I would say, a more pure, intellectual, humanistic thinking, if you will, for a lack of better word. And that is why I think we can provide inputs to try to get to the try to get the AI models to as close to they can be, so that they can augment that and help our workflows.
Thank you. Yeah, no, that is the radiology example is super interesting. There's a question in the chat from Adam. He's saying, as these models become online, what metrics should we be using to evaluate them? Like the traditional thing when any new intervention comes is, you do an RCT. Is anyone doing an RCT to say, hey, this is the best? I mean, you have shown some data, but that's sort of, using retrospective model thing. Is that like a prospective RCT saying, hey, this group with AI and this group doing the traditional standard of care? Is that best way to do it, to make sure all those hallucinations, possible limitations are covered?
That's a very good question, and I think so. I think we are at a prime time now where we need to start thinking about and doing as a standard RCTs for these AI models as they're coming. But RCTs take time. And I would think with how rapidly AI is evolving, but that by the time an RCT is conceptualized to started, that AI model might be stale to begin with, right? So we might have to even conceptualize a different paradigm of RCTs where they can intake these rapidly evolving models, and the RCT structure can keep up with that. Now, the other thing I would say is that RCTs rely on average treatment effects, right? So just because an RCT says that something works or something doesn't work, doesn't mean that it always works or always doesn't work, right? So some of this might be a combination of RCTs and some other artificial intelligence techniques. So for example, causal AI models, right? And doing target trial emulations using those to truly identify that if an intervention is there, and the intervention could be an AI model, but is that intervention just as a blanket helpful, as a blanket not helpful, or are there certain situations or certain patients or certain, processes for which it is still helpful and for some it's harmful?
Exactly right. No, thank you. I think we're just over time, but if you're okay, I can pick your brain a little bit, and other people are free to leave. But we are recording the Q&A. So some of the reluctance that clinicians have, like you pointed out, saying they don't trust the AI output, is because it's like a black box, right? That deep neural network you showed, which is hidden, and I don't know why it's telling me to do this, and that's why I don't trust it. And I guess you're going to say there is no way around it. You have to trust it. But for example, Epic has this deterioration index for the ward patients, not in the ICU. And it's not perfect, but whenever I'm on service, I do look at it and mostly it tells me what my intuition tells me about a patient. But there are some times when there's a mismatch, right? I don't think the patient is sick, but it's telling me it's sick. But if I click on it, it tells me what input is going into it. Like maybe the sodium is trending down, or maybe the respiratory rate has gone up, and I have not picked that up. And I do go and see those patients to see, okay, maybe I'm missing something. But there's nothing like that we can do with AI. Am I right? Like it's if there is a discordance between the AI output and my intuition, then maybe we should look closely at those patients.
No, absolutely. So yes, some of these models are black box in that it's not readily apparent, what the model is thinking, but there are now ways around it. We can identify, in a crude sense, what the coefficients are for each variable that is going in the model, right? Just like in a regression. It's not exactly that, but ballpark, yes, it can tell you that this model is making this prediction because the heart rate is this, which it is weighting very high, right? So you can see the weighting. It's not exactly a weighting scheme, but close enough that you can see how it is weighting different variables. For some of these very complex deep learning transformer models and all and even some of these very complex reinforcement learning models that we've developed, we also look at this weighting at every time step in a given patient to understand that as the model's recommendations or model's predictions are changing, does that clinically then make sense that now the model is weighting heart rate more over here, but few hours from now the model is now actually weighting creatinine more? Does that intuitively make sense to me as a clinician? And if it, yes, ballpark makes sense to me, then maybe it's the right call. Now that's also somewhat, I would say, biased, because I have my own biases in what should be the right weighting scheme. But that's where it comes down to having a group of content experts who can evaluate that. But if you have a group of ground truth from a group of content experts, then yes, some of those things can be peered into now.
Yeah, I remember a story about chess where AI has defeated humans a long time ago, but it seems that there is this thing called fusion chess where it's a human and a machine playing together against another human and another machine, or the program, what have you, and it seems like the best chess players are not really good at it because they don't always they are not able to evaluate the output coming from the stockfish or whatever the chess engine is.
Yeah, yeah.
Whereas the in between players, there are some people who are able to understand, hey, this is why perhaps this is when I should trust the engine, and maybe this is where I should not. And the strong players are not good at it. So maybe the junior our residents will probably be better than I am going to be. But last question, if you're still game, is that
Yeah,
some
absolutely.
of the biggest naysayers are about the energy usage of all these AI, right? Like I'm asking a simple question of, what's the dose of cephalexin in dialysis, and you're burning thousands of kilowatt hours to answer that simple question. Like again, it gets way more complex, I'm sure, with the kind of queries that you are talking about. What's the AI field think about, that sort of a criticism?
I think that's a very, very fair criticism, because these models um, are very heavy use in energy, right? I would I would say that as the AI use is getting integrated more and more, this is a problem that as a community we need to tackle and come up with solutions that can optimize this energy use. Because if we continue on that path, at some point, it is going to get unsustainable. I know there are some groups looking into this already. I don't think we have any very conclusive answers just as yet that can be operationalized. But that's a very, very fair point.
Yeah, we need more nuclear, like Microsoft buying 3 Mile Island, right? Like we need more something like that, right? It's not going to be enough with our current model. Anyway, thanks again, Ankit. Thanks for staying on longer and answering some of our questions. That was a really very interesting, very different kind of grand rounds. And we hope we'll chat again sometime.
Absolutely. Thank you so much again, Swapnil, for having me over. It was a pleasure. Thank you, everybody.